This is 371.
You know how I walk around with 10 bags all the time?
Yeah,
Like a little bag lady. All my bags are flying.
Theatrical performance of
Well, I'll tell you what, I wasn't happy
you know what?
It was very funny.
My whole swim bag on
He's in San Francisco. He's got them.
Probably just like
How embarrassing.
You ready, guys? Okay. Good morning.
Good morning.
Okay. We don't have to do it at the next class now. Okay. So I understand Dr. Lindblad didn't tell you that I was going to teach this class today. I teach the respiratory physiology, pathophysiology, but we don't cover that until towards the end of the semester in 311. So I've sort of struggled with this because we haven't gone over the anatomy that's really important to understand lung function. So I put some of the anatomy in here. When I have to come up with exam questions, I think I will include the anatomy as potential questions for you as well. Okay, as well as the testing we'll talk about. So pulmonary function tests, lung function tests, PFTs, LFTs, you'll see them called both. And you're probably familiar with some of them. Peak flow meters. You all seen peak flow meters? You done this in lab yet? No?
Blow into it and shows how high you
Sure, yeah. So it's a way of measuring lung function in a fairly simple way. I mean, it's a small device, you blow into it, and it tries to measure your peak flow. And that's a sort of good sort of estimate of the state of the larger conducting airways. And so it's good for, looking at whether someone's at risk for or of asthma, or if they're developing the symptoms of asthma. The lung function we'll talk about will include that, but it's sort of more complicated in terms of the test that you'll see if you go to a lab or a physician or something like that for lung function testing. And it's done with electronic devices now, but not always, obviously. So some of the first lung function testing reported was done by Galen, and this was thousands of years ago. And he was interested in just measuring the amount of air that was inspired and expired. And he did this by having people breathe into a pig's bladder. And it's sort of like this. And he sort of came up with a conclusion that, well, the amount that you inspire is exactly the same as the amount that you expire. And that seems pretty logical, really. But when you think about it, you breathe in air and you take in the oxygen. You think, well, maybe we breathe out a little bit less. Not so. It's the same volume. And he sort of looked at that, having people breathe in and out of a pig's bladder. Don't use pig bladders anymore. And this guy, Hutchinson, did a lot of work on what are sort of, the forerunners of today's spirometers. Spirometry is this lung function testing. And He came up with this device, and there were several iterations of it, and it's continued to develop. And until 10 years or so ago, this is what people used. Now it's all steady state electronics, and don't do that. But this sort of barrel inside a barrel, it sits on a bed of water, and when you breathe into it, it goes up and down. And you can have a pen that traces how much it goes up and down. You can measure volumes of breathing in and out from this. So this is sort of the early of the more modern spirometers developed by this guy Hutchinson. As I say, it's all sort of steady state now, and you won't see these things anymore. But when I first started training, that's what you saw a lot. No steady state. Okay. We'll talk about. Lung function testing is important for helping disease diagnosis, evaluating the severity of the disease, and for monitoring the efficacy of therapies. So you can look at changes in lung function over time, when you treat someone with a respiratory disease. It's important to know some of the anatomy to sort of understand and be able to put into place some of the different volumes that we're going to talk about. So we'll talk about spirometry, and the one that you're more familiar with, probably, with peak expiratory flow. You can't measure all volumes, lung volumes, with spirometry. And you have to, if you want to measure some of these other volumes, you have to do something called body. There's different ways of doing it, but the most common one is body plethysmography, where someone sits in a box, an airtight box, and breathes in and out, and you can measure, the total volume of air in the lungs, because the air in the. We'll talk about it. It's measure it by measuring the changes in pressure within this airtight box, and then. For some diseases, it's important to know the diffusing capacity across the airways. There's a way of measuring that by carbon monoxide inhalation. It's called the lung diffusing capacity carbon monoxide. It's either a steady state or a single breath test. And there are some other specialized tests that you'll come across, and I've got a couple of slides on those at the end. Anybody here had lung function testing done on them? Okay. A few. Disease diagnosis, evaluate signs and symptoms, screen for those at risk. Evaluation, if someone has a disease and you want to evaluate them in terms of whether they have a certain ability for exercise without causing problems, use lung function testing. Rehabilitate, do they need rehabilitation? You can use the lung function testing to determine that. And if someone's in hospital for operation and they have some pulmonary problems, might use lung function testing to see if you can predict that there's going to be any real risk during the operative procedure. For monitoring, follow the course of the disease. You can follow drug-induced changes in the disease. You can also look for drug-induced adverse effects on the airway system using spirometry. Okay. There's a couple of airway concepts that we need to sort of consider before we get into this, and we do cover this in the respiratory classes later in the semester. So, main goal of the lungs, the airways, bring in oxygen, take away CO2. To do this, you need ventilation, and you need a blood flow. You need perfusion, and you need to match these. So for optimal oxygen delivery, CO2 removal is less important here, but optimal O2 delivery requires this matching of the ventilation and perfusion. The normal resting alveolar ventilation is about 4 liters a minute. Now, total ventilation is more than that, but there's a certain amount of the air that you breathe in that doesn't get to the alveoli. It's called dead space. So the amount that gets to the alveoli is about 4 liters per minute. The normal resting alveolar capillary blood flow is about 5 liters per minute. And this is essentially cardiac output. Virtually all the cardiac output goes through the lungs. And so, alveolar capillary blood flow is cardiac output, about 5 liters a minute. So the normal ratio of ventilation perfusion, VQ, is you'll see referred to as, is about 0.8. So that's normal. This can change in diseases. Is there anything I missed here? No. Okay. The other thing that we will talk about is dead space. So this is the amount of air that you breathe in that is not involved in gas exchange. So if it's not in, I mean, gas exchange is what you want, because that's how you're going to get it, the O2 in, the CO2 out. There's a certain amount of air that does not get involved in gas exchange. And this dead space is either physiologic, which is like the conducting airways, the trachea, the bronchi, the airways that take the air into the lungs, but are not involved in gas exchange. It can be pathologic. So in certain conditions, you can have problems that will, you know, if you block off an airway, if you have obstruction, such as in COPD, you don't have airflow, but you might have blood flow to that part of the lung. So that is pathologic dead space. That gas is not going to be involved in gas exchange because it's not getting to the blood for exchange. Same the other way around. You could have a pulmonary embolism. So you could ventilate an airway, but if you've got a pulmonary embolism, you don't have blood flow. And so you don't have gas exchange. So the dead space where there's no gas exchange is physiologic, everybody's got it, or pathologic that you see in certain disease conditions. So we won't worry about the upper airways here, the nose, the nasopharynx, the pharynx. We'll start at the trachea. Okay. If you go from the trachea down to the alveoli, depending upon the person, there's something like 20 to 23 branches. So these are bifurcations. So I think if 2 to the power 20, I think is around 1 million. So 2 to the power 23 is around 8 million. So somewhere between 1 million and 8 million alveoli, or terminal airways. The conducting airways are the ones where there is no gas exchange. This is the dead space. This is the trachea and bronchi and most of the bronchioles. The difference between bronchi and bronchioles, trachea and bronchi contain cartilage and smooth muscle. The bronchioles contain no cartilage, but lots of smooth muscle. So no cartilage means that these airways can close off. The ones with cartilage cannot. So the bronchioles can close off. These are the major site of airway obstruction in bronchial asthma. We'll talk more about that. So that's the conducting airways. They're the ones that get the air to the alveoli, where there's the gas exchange. And so the gas exchange, the respiratory airways, just consider the alveoli. Bit more on the structure here. So this is a bronchus, and this purple, cartilage, C-shaped cartilage. So it's got some smooth muscle at the back here, and so it can change its diameter by constricting this smooth muscle at the back, but it can't close off because the cartilage prevents it from doing that. This is a bronchiole. See, there's no purple staining here, so no cartilage, but this is smooth muscle, a ton of smooth muscle here. So this airway can close off. This is showing the alveoli. So these are the alveolar sacs when you get down to the terminal bronchioles. There are some bronchioles where you may have some gas exchange. They call them respiratory bronchioles. Don't worry about that. 99.9% of the gas exchange takes place in the alveoli. So think of the gas exchange, think alveoli. So trachea, bronchi, bronchioles, alveoli. The interesting thing is with these bronchioles, because of the structure of the airways, as I said, they can collapse. What happens is when you, because of their attachments to the other tissues, when you inspire, when you breathe in, these bronchioles expand. And when you breathe out, they get smaller. And so if you breathe out far enough, they close off. And what happens then is they trap gas behind them. That is called residual volume. That is gas that you can't breathe out. And This volume at which these bronchioles close can increase in lung diseases because of inflammation and things like that. So you trap more gas behind them. You have a bigger residual volume in some lung diseases. And you don't need to remember the structure of this. For this class, the alveoli, the important things are that it's a real thin membrane. You've got capillaries one side, air the other. You've got a couple of basement membranes. You've got some interstitium with some elastic fibers. It's real thin, and that's important for optimal gas exchange between the air and the blood. The other thing that's important is that it's a huge surface area. So important for gas exchange. Large surface area, real thin membrane, and that's all you need to really remember from this line for this course. Okay, not for patho, but for this one. So what we'll talk about is lung function testing, and you think about it's important in looking at these types of diseases. The obstructive diseases that affect mainly the conducting airways, asthma, COPD, and there's something now called asthma COPD crossover syndrome, where people have symptoms of both diseases, and something like cystic fibrosis, where there's a lot of infections, inflammation in the conducting airways. Now, also COPD has a component called emphysema, which affects the alveoli, but it used to be two separate diseases. Now, chronic bronchitis and emphysema, now they put them together because the major factor in both is cigarette smoking. So COPD. But I'll put it under obstructive rather than the ones that affect the alveoli, which are considered restrictive diseases. So restrictive, more alveolar changes here, and one of the most common ones that we will talk about later, idiopathic pulmonary fibrosis, where you get fibrosis of the alveolar interstitium. It thickens the membrane and decreases gas exchange. Okay. These are some of the, I put these slides together fairly quickly, and I missed some things out, and I've changed some things. So the things that I've changed are in red, and I can send these slides to you directly if you like, the ones that have been changed. So we'll talk about total lung capacity, vital capacity, forced vital capacity, which in a normal lung is the same, and then something that you may come across called slow vital capacity. When you breathe out with a forced expiration, you can cause the small airways to close off earlier, especially in someone who has got airway obstruction, such as in COPD. And so normal lung function testing is, a very fast expiration, but in someone with COPD, that could give you a false reading for the vital capacity. So sometimes in people with COPD, they will do something called the slow vital capacity as well, where you do the same maneuver, but it's not a forced expiration. We'll talk a bit more about that. I mentioned residual volume. A really important one is the forced expired volume in 1 second, FEV1. This is a good indicator of the state of the conducting airways, the trachea, the bronchi, and most of the bronchioles. Okay. And then there are some others that you'll see mentioned that we won't get into. Okay. You'll see this sort of picture in most of the textbooks. And again, it goes through some of these lung volumes. Resting tidal volume is your just normal breathing in and out. It's about half a liter, 15 times per minute. So your total ventilation, young, normal, healthy subjects, is about 7.5 liters per minute. Now remember I said that the alveolar ventilation is only about 4 liters per minute. This other, ventilation, the almost 3 liters per minute, is dead space. So you're ventilating the dead space a lot. This is the conducting airways, just the trachea, the bronchi, the bronchioles. Total lung capacity is as far as you can breathe in. And then as far as you can breathe out is called residual volume. So residual volume is the air that you cannot breathe out no matter how hard you try, because the airways are closing off. It's trapping the gas. So the important ones, vital capacity, total lung capacity is the whole volume of the air in the lungs. Vital capacity is the volume of air that you can actually access, inspiring, expiring. You can inspire to maximum inspiration, total lung capacity here, and you can expire to residual volume. So this is your vital capacity. And this is your normal breathing here. This is residual volume. This is as far as you can breathe out. So lung function testing with a spirometer measures most of the important volumes, not all of them. Some of them, total lung capacity, residual volume, you cannot measure with a spirometer. So this is where we'll talk about, you can do it with a gas dilution method. The most common one you'll see is body plethysmography, and I've got a slide on that afterwards. Okay. Anybody done? Well, I've asked a couple of you. A couple of you have done spirometry. Okay. The way it's done is that you typically breathe in as far as you can, total lung capacity, and then breathe out as far and as fast as you can. Okay. And from that, they will measure the force expired volume in 1 second and the total amount that you can breathe out, which is your vital capacity. And what's left is your residual volume. So there'll be force vital capacity, the FVC, and the FEV1, the amount that you breathe out in 1 second. So this is the machine that is done with these days. I say it's no spirometers, no drums on beds of water. It's all electronic, steady state. Okay. And this is you've seen this. This is a peak flow meter. So this is not the same as FEV1, but it gets at the same thing. It's a sort of an indicator of the state of the larger conducting airways. And when that starts going down, it's indicative of constriction in the bronchioles. So someone who has asthma and their peak expired flow starts to go down, maybe it's a sign that they are in risk of having an acute asthma attack or something like that. My older daughter, when she was younger, had asthma, and we used to measure her peak flow, and when it started going down, it was a sure sign that she was getting a lung infection, a cold or something like that. And he was starting to decrease lung function. So, indicative of risk and things like that. So, how are these data looked at? So, this is a little bit different here. This is a flow volume loop. So, what I've just talked about here, this is flow versus volume. This is maximal inspiration here, so total lung capacity. Breathing out as far and as fast as someone can, all the way down to residual volume. So this is what a flow volume loop looks like on forced expiration. And in this maneuver here, there was also, once it got to there, the person got to there was a forced inspiration, all the way back to total lung capacity. So this is a flow volume loop showing a forced expiration and a forced inspiration. And what you see is that, initially, real fast flows, and these slow down until you get to residual volume. And it's almost a mirror here of when you do this forced inspiration. I mentioned this is showing vital capacity here, and this is the vital capacity. So this is from total lung capacity, maximal inspiration, all the way down to residual volume. This is vital capacity. Some of these airways, if someone has obstruction, may start closing off down here. Now, this would be a normal person, and forced vital capacity and vital capacity are the same in a normal, healthy lung. Say in a diseased lung, it may not be. You may get some closure if it's a forced expiration, so you won't measure the total vital capacity. So if you have someone with COPD, they may have them do this as a slow maneuver. So yes, you won't get the forced expired volume in 1 second, but you'll get the total amount of vital capacity, because their airways, if you do it slowly, won't close off the way they do when you do a forced expiration. Is that clear? Okay. When you do a forced expiration, it puts more pressure around around those airways, and they can collapse easier than if you just do it very slowly.
I'm sorry, I have a question about the previous slide. How are we reading that volume? Is that volume inside the lungs? Because it's counterintuitive.
Yeah. This is
Maximum
this is
inspiration, when you've got the biggest breath in,
as far as you can breathe in,
and volume
and
zero.
then all the way down until you cannot breathe out any more air.
Okay,
Residual volume.
So what's our x-axis there?
This is volume.
Yes, volume inside the lungs, outside the lungs.
This is
Oh.
well, yes, and yes. Okay. You know, this is the volume inside the lungs. Then you breathe it all out until you get to residual volume. This is your total lung capacity.
Yeah.
Okay.
So in this case, it'd be 4.5, somewhere around there.
Yeah, about that. Right. So that's one way that you see the data plotted as a flow volume loop. More commonly, this is what you will see. This is the forced expiration versus time. So from total lung capacity, breathe out as far and as fast as you can, this is the amount breathed out in 1 second. So this will be the FEV1, and this will be the total amount that you can breathe out. So down to residual volume. So again, forced vital capacity from total lung capacity down to residual volume, the amount of air that you can breathe out or you have access to, and then the amount that you've breathed out in 1 second, okay, as fast as you can. And in a normal healthy lung, forced vital capacity is about 5 liters. FEV1 is about 4 liters. So you can breathe out about 80% of your forced vital capacity in 1 second. So these are important numbers: 5 liters, 4 liters, and 80%. This is a normal healthy lung. So it varies between genders. It varies between age, and it varies between body size. So bigger people, bigger lungs. So the volumes are going to be more. So there are sort of standard numbers for different age groups, different genders, well, the two genders, and height. So you can come up with a predicted number for someone of that gender, age, and height. But if you remember 5 liters and 4 liters and 80%, that's what you need for now. Okay. If you look in the textbook, and this is the course textbook, they have this picture in here. This is a flow volume loop, and this is a volume time curve. And I've just shown you the first part here, but it shows you more or less getting to residual volume, and this is the amount expired in 1 second. So this is forced vital capacity, and in this person, which was only about 4 liters, and the FEV1, which was about 3-point-something liters. Okay. So obviously not a young, healthy person like you guys. Okay. How is lung function testing helpful? Well, it's important in looking at disease states. So what happens in disease states? So let's just focus for the moment on this, the volume time curve that I showed you. Normal, 5 liters, 4 liters FEV1, 80% of the forced vital capacity. In an obstructive disease like COPD and asthma, the forced vital capacity is decreased, the FEV1 is decreased, and the FEV1 as a percent of the forced vital capacity is decreased. So in obstructive disease, all of these numbers are decreased. In a restrictive disease, fibrosis, affects the alveoli, but not the conducting airways. Again, the forced vital capacity and FEV1 are decreased, But the FEV1 as a percent of the forced vital capacity is usually normal. It can even be increased, but if you just think of it as normal, that's good enough. So this is a different picture in a restrictive disease versus an obstructive disease such as COPD and asthma. Asthma, COPD mainly affecting the conducting airways. Restrictive disease mainly affecting the alveoli. Okay, so the respiratory airways. And if you look at the pictures, this is what you'd see. This is normal. This is obstructive. So forced vital capacity is lower here, but the FEV1 is greatly reduced in terms of percent, and this is exaggerated. It's usually not quite that much unless you have some very severe disease. And then this is restrictive. So they're both decreased, but the FEV1 as a percent is not changed. Giancarlo.
So what's obstructing the airways?
In obstructive disease, what's obstructing it? It depends. COPD, it's airway inflammation, it's mucus. Those are the main things. And then you get hypertrophy of the airway structures as well. So you're closing off the lumen of the conducting airways. Mainly, you'll see some in the trachea, but it's mainly the bronchi, the bronchioles where you see these changes. So tissue inflammation, airway mucus, tissue hypertrophy. Bronchial asthma, you get some mucus in bronchial asthma, but it's mainly, again, you get an inflammatory response, immune inflammatory response. You get more smooth muscle contraction in bronchial asthma. So that's what's blocking off the airways in these conditions. And then cystic fibrosis, again, you get lots of infections in CF, which causes airway changes as well. Okay. I'm not sure you'll see these much, but they do go over them in the textbook, so I've put it in here for you. You can also look at these flow volume loops and see changes in diseases. I think most of the diagnosis, at least in primary care physicians, is going to be done just on normal pulmonary function, but rather than flow volume loops. But this is what they look like. So this is a normal person. Okay. Let's look at the obstructive first. We said that all the volumes are decreased. Well, flows are decreased as well, especially expiratory flows in obstructive disease. So the expiratory flows in obstructive disease here are much lower than those in normal subjects. Less so in restrictive. Restrictive expiratory flows are sort of normal, and that's suggesting that there's no real larger conducting airway changes in restrictive diseases. It's mainly an alveolar condition. This is showing the airway obstruction in these central conducting airways. Residual volume is increased in restrictive and obstructive diseases. It tends to be increased more in obstructive, but you do see increase in residual volume, which means that the smaller bronchioles or the smaller airways are closing off and trapping more gas behind them. Ravi.
Yeah, how does in the first diagram in restrictive the expiration so is actually 8?
Right. I say the expiratory flows in restrictive disease are fairly normal because it's these expiratory flows are indicative of the conducting airways, and in restrictive diseases you don't see changes in conducting airways. I'm not saying never, but for restrictive, think of alveoli, change in the alveoli. COPD and asthma, think largely conducting airway changes. Okay. Here.
In case of obstructive, does the lung between the smaller and how much air it can hold? If it's obstructive, does that mean the lung basically can't hold as much air?
No, you can't access as much air in the lung. Your total lung capacity could be the same. Okay. But it means that you can't breathe out as much. These airways are closing off. So the amount of your total lung capacity that you can actually access is less. Your vital capacity is less. Total lung capacity could be certainly the same or even more in COPD. You start losing alveolar structure, and so that sort of can maintain total lung capacity, but it doesn't. You cannot access that air that's there. Okay. So total lung capacity is the whole air in the lungs, but you cannot access it all. What you can access is your vital capacity, and that goes down in obstructive and restrictive diseases. Okay, so bronchioles collapse, airway narrowing in obstructive diseases is one of the main reasons for this. You get increased lung elasticity in fibrotic diseases, which can also lead to a collapse of small airways. And so one of the things that you'll see in people with certainly obstructive diseases, something called barrel-chested. They'll be breathing at a higher lung volume, and that is to try and keep these smaller airways open for longer. That's for the next class, not for this one. Okay. Lung function testing. Help diagnose asthma. So some repetition here. So this is the normal values in asthma. They're all decreased. Both volumes are decreased, and the FEV1 as a percent is decreased. And the amount that it's decreased is an indication of the severity of the disease at that time. Okay. Some asthmatics could have a fairly normal FEV1 percent. If they have mild asthma, they're not having an acute attack. But more severe chronic asthma or someone during an acute attack of asthma is going to have a decrease in the FEV1 percent. The thing about asthma is that these differences here, if you give someone a bronchodilator, then you can improve lung function. And asthma is often diagnosed by having a reversibility, an increase of 12% or more, 250 mils or more increase in FEV1 when they're given the beta-2 bronchodilator. And so that would help in the diagnosis of reversible airway disease, i.e. bronchial asthma. Okay. COPD, similar. Volumes are decreased, and FEV1 as a percent of forced vital capacity is decreased, just like in asthma. There are some what they call the GOLD criteria, the Global Initiative for Obstructive Lung Disease. And they've come up with the criteria for diagnosing COPD and staging COPD in terms of severity. And this leads into helping determine what treatments should be given. And an FEV1 percent of less than 70% is a diagnosis of COPD. And then what they look at for severity is the FEV1 percent as a percent predicted. We all have a percent predicted FEV1. And so they look at that percent predicted, and in COPD, it is less than that, and how much less determines what they classified as mild, moderate, or severe. So this is the GOLD classification. FEV1 percent less than 70% is a diagnosis of COPD by these criteria. They then look at the FEV1 as a percent predicted. This is not the percent of the forced vital capacity, but as a percent of what it should be. It gives the staging. So greater than 80%, of the normal value, mild. 50 to 80, moderate, etc. And getting down to less than 30% of the normal value of FEV1 is considered very severe COPD. This slide will not be on the exam for this class. maybe for patho, okay, because we're going to come back to this. Okay. So spirometry measures most of the, important lung volumes, lung capacities. There's a couple of important ones it does not measure. It cannot measure total lung capacity, and it cannot measure residual volume. So it can't get at it can't get at the air that you can't get at. So residual volume, this is the air you can't breathe out. You don't know how big that volume is. And since that's part of total lung capacity, you don't know your total lung capacity as an absolute volume because you can't measure residual volume. There are methods to measure both of these. One is an indicator gas dilution, where you breathe a gas that you can use as a marker, and when you exhale, you measure how much it's been diluted, so you can come up with an idea of how much air there is there. But it only measures the ventilated areas of the lungs. So if the gas that you breathe in doesn't get to a certain region of lung, then it's not going to include that in the calculation. You can use CT or MRI. This can also show you structure, but it is not as good a measure as in terms of volume as the body plethysmography. Plus, you're giving someone radiation, and it's expensive. So body plethysmography is the most common method that you will see. And what happens is that the subject sits in an airtight box, breathe through a mouthpiece that's connected to the outside, and they can put a shutter across this mouthpiece. And so the person can continue breathing, but there's no air movement because the shutter is closed. And that just changes the pressure, within the box. So airtight box, breathe against a closed shutter, you measure the pressure. Coming back to basic physics here, Boyle's law. Pressure 1 times volume 1 equals pressure 2 times volume 2. And from this, you can calculate the total amount of gas that is in the lungs. And so from that, if you've got TLC and you know that the vital capacity, then you know residual volume. So whole body plethysmography is the typical way that you'll measure these volumes that you can't get at with spirometry. And this is a whole body plethysmograph. Okay. So they're measuring, breathing in and out, they're measuring pressures, and they can close off the shutter, do all sorts of things. So you can do the whole spirometry maneuver here, and also measure total lung capacity. Okay. Changes in diseases. Obstructive and restrictive diseases, as we saw on the flow volume loops, are associated with increased residual volume. The airways are closing off sooner, trapping more gas in the lungs. In COPD, the total lung capacity may be normal, may even be increased because of the emphysema. The emphysema is the part of the disease that destroys the alveolar tissue. So there's breakdown of the alveolar structure. And in COPD, this can be seen as an increase in total lung capacity. Now, that's not a good thing. This is, more gas in the lungs, but it's not gas that can be exchanged because the alveoli have been destroyed. Plus, again, it's not necessarily gas that can be accessed by the respiration. But in terms of measuring total lung capacity in COPD, it is probably normal. Fibrosis, total lung capacity is decreased. And this is caused by these changes in fibrotic changes in the alveoli. Any questions? Okay. Ravi.
But I have the previous slide. So if there's more gas volume in emphysema, why wouldn't it lead to more gas coming out, like expiration? In SCV, would that lead to an increased FEV1?
No. No. Yeah. The FEV1 is really an indicator of what's happening in the central airways. So if you've got more alveolar gas, that's certainly not going to, but you've got obstruction in the central airways. It's the obstruction in the central airways that determines the FEV1. Okay. So one of the other tests you will see, Giancarlo.
So when we're talking about increasing gas in the lungs, we're pretty much talking about CO2 increases, not being able to convert that oxygen to damage to the
No, I mean the lack of gas exchange is going to decrease oxygen transfer and CO2. Less CO2 transfer. CO2 is easier to transfer because it's more soluble than oxygen. We'll talk about that in pathway. Okay. So gas diffusion between the alveoli and the blood is an important feature here. And it's governed by fixed law of diffusion. Okay. And the important things to remember here is that it's a large surface area and it is a very thin membrane. So for optimal gas exchange, yes, it's large, and the distance it's got to diffuse is real small. It's very thin. Okay. What happens in emphysema is that there's loss of alveolar structure. So there's loss of surface area for gas exchange. Yes, there's more volume there, but the actual surface area for gas exchange is decreased. In fibrosis, the membrane becomes thicker. So these are two important factors that determine the diffusion. So you lose area, diffusion goes down. You thicken the membrane, rate of diffusion goes down. So there is less gas exchange in the alveoli in people with emphysema and in people with lung fibrosis. And it's important to know, the level of this. So there's a test that you will come across that measures the lung diffusing capacity. Makes use of carbon monoxide. Carbon monoxide, not normally in the lungs. It's easily transferred, high affinity for hemoglobin in red blood cells, easy to measure. So they use carbon monoxide. They don't use it in levels that are going to be really detrimental to you. There's either a single breath test, which I think is the most common, or a steady state test. The single breath, take a deep breath to total lung capacity of air containing 0.3% carbon monoxide. Hold for 10 seconds, exhale, and then you measure the carbon monoxide in the exhaled air. So you know what you put in there, and you can measure what comes out, so you can calculate what was transferred into the blood. And the normal transfer is 25 to 30 mils per minute per millimeter of mercury pressure. And if it's significantly lower than that, then, or less than 70% of that, that is considered abnormal. Okay. There's a steady state test where you breathe in and out of with air with a CO2 concentration for 5 to 6 minutes, but then you have to analyze the carbon monoxide in the blood. And the values it gives you are not too different from the single breath test. So I think the single breath test is the most common one that you will see. Anything less than 70% is considered abnormal or abnormally low diffusing capacity. Again, it varies with age, it varies with gender. There are a few specialized tests. These are listed in the textbook. Bronchial provocation tests. This is where we're trying to determine if someone has bronchial asthma, airway hyperreactivity. I think most times the asthma is diagnosed from signs and symptoms without going to these bronchial provocation tests, but you will see them. And it's where you give someone an inhalation of a known bronchoconstrictor. What is usually used is either histamine or methacholine. Methacholine is a cholinergic agonist. It constricts bronchial smooth muscle. Histamine also can cause constriction of bronchial smooth muscle. And then you increase the dose until you decrease FEV1 by a certain percent, and it's usually 20%. And from that dose that you need to decrease FEV1 by 20%, you can determine when someone has, airway hyperreactivity or not. Exercise challenge test. This is to determine if someone has exercise-induced bronchospasm or exercise-induced asthma. Treadmill exercise to a certain level, increase the heart rate, and then you measure FEV1 before and after exercise. And anything that greater than a 10% decrease with exercise is considered exercise-induced bronchospasm. I'm not familiar with the 6-minute walk test, but it's where they ask someone to walk as far as they can, as fast as they can in 6 minutes. And it's to determine the requirement for home oxygen therapy in someone with COPD. I'll just mention this last one. We'll talk more about it during asthma, but there is one now called the fractional exhaled nitric oxide test. Nitric oxide is produced by eosinophils, and it's being used as a measure of eosinophilic inflammation in the airways. So most people with allergic asthma, it's driven by eosinophils, and so they can try and diagnose it with the nitric oxide that's being produced, but also they can track therapy. So if you start treating someone with steroids or something like that, you can see where the nitric oxide comes down. And although, to me, lung function is still going to be the one way of determining that. Right.
The FEV1 is just basically a measure of the alveoli.
So
the FEV1 is it's like a direct measure of the alveoli.
the FEV1 is conducting airway. Trachea, bronchi, bronchial.
Okay. So it's nothing.
The only way you measure alveolar function is with this diffusing capacity. Okay. Thanks, guys. See you in 10 minutes.
Don't worry about it.
You did?
Yeah. You know what? I'm upset. Don't be upset somewhere else. You know it's great.
Yeah, I can't explain right now.
Yeah, I know. Yes, it's a song. It's called I'm Upset. Yeah. I find it the beats that they used to say. I'm sorry, I didn't mean it. Nah. Games where they see about people. Drake is just outside.